The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
Thanks, y'all, for letting me discuss this important issue for men. So urinary issues can make a huge difference to the quality of life of men, especially when they start having leakage of urine. It can become a huge burden to their quality of life. But before we can start to talk about some solutions, we got to talk about the way the urinary process should work. So as a lot of you may probably know, the urine is actually made in the kidneys, which are two structures that are kind of in the flanks or in the back of the abdomen. The urine then drains down two little tubes called the ureters, and it gets stored in the urinary bladder. You can see that in that cartoon there. That's this muscular wall, kind of a spherical organ that squeezes the urine out. And as it squeezes the urine out, it squeezes it through a tube called the urethra that runs through the penis. It's the muscle contraction that's doing all the work. When the bladder is quiet and it's not squeezing the urine out, the urine can stay in that reservoir. But when the bladder contracts, the sphincter opens up, the valve opens up, then the urine is able to exit the body. So what is urinary incontinence? What causes it? How common is it? We're going to explore some of these issues because it's become a big issue for men. So when a man has urinary incontinence, there's multiple different types. It often helps to categorize things. That way we can better identify how to help a patient. Stress incontinence is almost like a leaky faucet. So like I mentioned, when that urinary bladder squeezes, the urine comes out, but that valve has got to open up as well so that the urine can exit. That valve is called the urinary sphincter. When that urinary sphincter is not strong enough, that valve does not close quite enough, then what happens is it's like, again, like a leaky faucet, like a drip, 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 the urine is able to just leak out. If there's a high pressure environment in the bladder, like if the bladder is squeezing, or if a man is working out or coughing or laughing or creating any sort of additional pressure in the lower abdomen, which is where the bladder sits, then the urine just gets pushed and that valve is not stopping it and it just leaks right out. So what causes that valve or that sphincter to get weak? If you have a weak pelvic floor muscle, so all the muscles around the valve, around the sphincter are not functioning nicely. Prostate removal surgery is probably one of the most common causes. When you remove the prostate, you're kind of pulling and tugging at that sphincter, so it starts to weaken. You also remove some of the nerves that control that sphincter, so it's unable to squeeze as tight as it needs to. Radiation therapy for prostate cancer also causes an issue. I'll tell you, it's not just prostate cancer surgery, it's also bladder surgeries, as well as certain colorectal surgeries, like when the rectum is removed and things like that. That whole area of the pelvic floor muscle can get damaged at that time, the muscle and the nerves, and then you end up with this leaky valve, and that's what stress urinary incontinence is. Urge urinary incontinence is the other form of urinary incontinence. So that's when your valve works, but the bladder just squeezes so hard that it overwhelms that valve. So it's squeezing so hard that it just pushes right through and it leaks right out. So that's when you kind of feel this sudden urge, oh, I got to go to the bathroom, but you just can't make it in time because it squeezes too fast, and then you leak the urine out. That's an involuntary contraction of the urinary bladder. It's often called overactive bladder. It can occur due to conditions like multiple sclerosis, Parkinson's disease, sometimes spinal cord injuries, sometimes just habit of holding your urine for long periods of time, so those muscles gets really thick and strong, and it's just too strong for the valve over time. These are the things that cause urge urinary incontinence. Those are the two most common. Stress and urge, by far, are the two most common forms of urinary incontinence in men. Another one, which is worth noting, is overflow incontinence. That's when you're unable to fully empty your bladder. So you fill up the tank, which is the bladder, but when you pee, almost none of it comes out. Then it fills up again, and then almost none of it comes back. You're sitting with a full bladder all the time. And when your bladder is really full, any additional urine that you make, there's nowhere for it to go. so it leaks out. It's kind of like, again, it's overwhelming the valve, not because your bladder is squeezing, but just because there's no room left in the bladder, so it has nowhere to go but out. That's a special form of urinary incontinence. It tends to occur because of severe enlarged prostate situations over a long term, over years and years and years, or blockage of the urethra with a stricture or a stone, some type of blockage within the urethra itself, which can be due to trauma or radiation or other specialized circumstances. Neurogenic incontinence, I already talked about. It's actually usually urge incontinence, but we use that as a special title because it's due to a neurologic cause like spinal cord damage, nerve damage, things like that. There's two that you really need to understand. It's stress and urge. Those are the two most common. So how common is urinary incontinence? Up to 10% of men. So over 1 in 10 men is going to experience urinary incontinence, which can be moderate to severe, which is what we characterize as something that could actually inhibit someone's quality of life. It does increase with age, but it doesn't mean that just because you're getting older, you need to have it. You can expect incontinence. I get too many patients that show up way too late. They say, oh, you know what? I just thought I was getting older. This is what happens. You know, you don't need to settle. It's not a natural consequence of aging, although it does occur to people as we get older. The vast majority are urge urinary incontinence. That's when the bladder is overactive and squeezing when you can't. About less than 10% are pure stress urinary incontinence. We're saying 10 to 30 are mixed stress and urge, although I'd say it's probably a little bit more than that. I see a lot of mixed kind of multifactorial, we call it, urinary incontinence. All right, so we started to talk a little bit about this. We can go to the next slide, about male stress urinary incontinence and prostate cancer treatment. So one of the biggest reasons for stress urinary incontinence, again, is prostate cancer treatment. Over 70,000 prostatectomies are performed per year in the United States. Prostate cancer is one of the most common forms of cancer for men in the US and worldwide. It's estimated about 1 in 8 men will be diagnosed with prostate cancer at some point in their life in the United States. Doesn't mean everyone has their prostate removed. There are only certain special circumstances where treatment is required at all, and even in those, only certain ones where you would think about actually removing the prostate. But when you do remove the prostate, you can have damage to the nerves and to the urethral sphincter, where it gets pulled or tugged, and that valve just isn't working well anymore. It's not getting the right signals to stay tight, and even if it's getting the signals, it doesn't have the capacity to tighten up because it's been damaged by the surgery. Majority of men will report some form of leakage after surgery, but there are therapies that are available, pelvic floor physiotherapy, Kegels exercises, different forms of rehabilitation that allow that sphincter to kind of gain its strength again. But up to about, they say 9 to 16% of men will have continued leakage up to a year afterwards. Once you cross that year mark, frankly, a lot of research is saying once you cross that 6-month mark, if you're still having leakage after prostate cancer surgery, there's a high likelihood that it's going to remain for a longer period of time. So you want to start to be a little more aggressive about the way that you treat it. You can also get stress urinary incontinence, again, not just from prostate cancer surgery, but other forms of surgery, pelvic trauma, where you've been hit, you've hurt, or neurologic disorders. So what are some of those ways that we can treat? Okay, so this is I like the slide because it kind of goes to the amount of invasiveness. We always start with behavioral modifications and aids. A good bladder diet and bladder training is very helpful. There's certain foods and drinks that are particularly irritating to the bladder. This is particularly important for that urge urinary incontinence where the bladder is squeezing when it's not supposed to squeeze. All the good stuff, unfortunately, coffee, tea, alcohol, carbonated beverages, so anything that's carbonated is very acidic. These kinds of liquids are very irritating to the bladder. Artificial sugars is another big one. Certain foods, like very spicy foods or very acidic foods, like heavily tomato-based foods, they can often make the urine a little bit more caustic, which can make that overactive bladder even more overactive. So it's like putting fuel on the fire when you already have this dysfunctional bladder. When you clear, I tell patients to detox, drink nothing but water for a while until we get things under control. it can make a big difference, and you slowly add those bladder, unfavorable foods and drinks afterwards once you've got things under control. Bladder training is also very helpful. Timed voids, so kind of going to the bathroom every 3 hours during the day. Double voids, where you kind of teach your bladder to be completely empty by giving yourself a second chance. Pelvic floor exercises. There are 2 types of pelvic floor exercises. For stress urinary incontinence, when that valve is not working properly and it's unable to kink things off, you want to do bladder pelvic floor strengthening exercises. So those are called Kegels. There are also other forms where you teach those muscles to get a lot tighter and wrap around and close things off. If you have urge urinary incontinence, you want to do different exercises which relax the bladder itself, because the bladder is squeezing too hard, and you can work with a pelvic floor physiotherapist that's skilled. We do external kind of therapies where we can do external massages to certain muscle groups like the thighs and the pelvic muscles to kind of help everything relax. As well as biofeedback, so you have a better awareness of how to relax those muscles for yourself. None of this requires medication, none of this requires surgery, so I always start with this stuff first. You can also do, of course, the pads and the underwear, penile clamps, catheters. I'm not a big fan of any of that stuff, of course, but some of them can be helpful. Penile clamps, for example, in a pinch can help you get outside, so you can allow a little bit of freedom, but we don't want that to be your long-term solution. Medications are the next step. Again, there's 2 types of incontinence. If you have that urge urinary incontinence, you want those medications that will relax the bladder so it's not squeezing so tight and helping and pushing all the urine out. Beta adrenergic agonists and Gemtesa are very helpful. PDE5 inhibitors like Cialis also relax things a little bit. The alpha blocker is a specialized medication. It's called Flomax, is probably the most popular, although there's a whole slew of them. What that does is it actually opens up the urethra, so there's less pressure on the bladder. Less pressure on the bladder means that it can actually heal and it loses overactivity. And that's why that helps with incontinence. The other is anticholinergics. These are kind of almost bladder paralytics, where they make it so the bladder doesn't squeeze so much. And again, it's for the urge incontinence. So if you have the urge incontinence, a lot of these medications are quite helpful. Unfortunately, there aren't really great medications for stress urinary incontinence. So that stress incontinence where it's like a leaky faucet and the valve is not so strong, unfortunately, the meds don't work so well for that. For that, you often need surgical procedures. There's a Sling procedure, which is the first one that's listed. I do this very often. Sling is a small piece of mesh, and this is different than a female mesh where that's caused a lot of complications. In the male population, it's a very, very low complication rate. What the Sling does, it's a quick surgery, and it kind of pulls the urethra up into a more favorable position so your natural valve can kind of work more efficiently. And we'll talk more about that. Artificial urinary sphincter is put a new valve in. This valve isn't working, your natural valve, you put a new one in. It's as straightforward as that, although we'll kind of go over the more details about that as well. That's for stress urinary incontinence. For urge urinary incontinence, again, when your bladder is overactive and it's squeezing when it's not supposed to squeeze, you can use bladder Botox therapy. That's where you do a quick 10-minute procedure. You inject a little bit of medicine into the urinary bladder. What it does is actually paralyzes the bladder partially, so it's not squeezing so hard and not overwhelming the valve and making sure that you can have more time to get to the bathroom so you get to pee before you leak. Sacral neuromodulation systems like the InterStim and other related devices are also very helpful. These are almost like bladder pacemakers. They're little implants that are done, 2 procedures, about 15 minutes or so each, where you go in and you put these little devices in and they actually stimulate the bladder so that the nerves are functioning more correctly and not squeezing when they're not supposed to squeeze. There are a lot of exciting procedures as well as medications and behavioral treatment options that are there to help men with incontinence. We talked about the diet. Again, you avoid that spicy food, the caffeine intake. Another really important one listed here that I did not go over, coffee, tea, of course. Energy drinks, they're a big problem in terms of overactive bladder. Chocolate, and frankly, any cocoa-based products can also cause irritation to the bladder. Fruit juices, which are acidic, like citrus juices. Alcohol is another big one, and carbonated beverages. Bladder training, use that bathroom on a scheduled basis, and that'll kind of help to retrain your bladder as to the normal kind of way to urinate. You want to empty that bladder completely, which is why you do double voids. When you think you're done urinating, take a moment, clean your glasses, fix your hair, whatever you're going to do, go back to the bathroom. Go back to the bathroom and give yourself a second chance to urinate. That's very important because you want to teach the bladder to completely empty and then completely fill on a regular basis, and that's bladder retraining. Some people, they find it leaning forward with like a rocking motion can induce urination. That's because you're changing the amount of pressure that's pushing on the bladder and the location of it, and that can actually really help you going from a standing to sitting position. Some people like the other way. You can contract your pelvic and bladder muscles during urination. That's called a Kegels exercise. That's good for stress urinary incontinence. So if you have that leaky faucet, like a drip, 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 where your valve isn't working, you want to teach yourself how to tighten those muscles. And that's one way to kind of become more aware of the muscles that you need to exercise. And that's what pelvic floor exercises come into. Incontinence care aids, we talked about pads. They're great, in a pinch. They allow you to get outside. You can kind of change them so, you have some more freedom. You're not leaking all the time. It's not saturating into your underwear. But, I don't like these as a long-term solution unless we really have no choice. A little bit better is this leak-proof underwear. This one is actually available through MenMD. I like this. Because, the pads are good because they sit there, but the problem is they can move, they can bunch up, and they're not quite as sealed, so a little bit of smell can come out. This leak-proof underwear is nice if you're going to use something as a barrier protection, just because it kind of keeps everything packed into place, so it's a little bit easier to take, when you go outside of the house. Penile clamps are really good, as well as a short-term solution. What they do for people with stress urinary incontinence, they actually go around the penis itself and pinch it. It's like a similar concept to a clothespin, but obviously it's much more padded, so it doesn't cause a lot of discomfort. You don't want to use something that's too hard if you choose to do this, just because you don't want to create pressure ulcers or pressure on the penis, which can result in wounds and pain. But if you use something that's comfortable, you want to apply the proper amount of pressure, you want it fitted properly so it fits nicely. All those are important to look in a penile clamp used for stress urinary incontinence. And one of those, of course, MenMD as well. I kind of like their design. It's a little bit more rounded rather than the flat shape, so it allows for a little bit more comfort when a man is wearing it. Catheter is the last option. I really hate long-term catheters. Catheters, they go directly into the penis and into the bladder, so the urine is constantly draining. But the reason I don't like them is because they're a nidus for infection. When you've got a piece of plastic going from the outside world into the inside world, that's a highway for bacteria to go in and out, and you can have a higher risk of infections, which is known, proven, described in the literature if you have a catheter in place. Sometimes you can use an externalized catheter. This is a little bit better. It kind of almost has a condom shape to it, and it goes on the outside of the penis and, kind of affixes on it almost like a condom does on the outside, and then the urine goes into a bag from there. If you're going to use a catheter, that's the one that you'd prefer, just because it's not going into the bladder, so it's not giving a pathway for the bacteria to go in. These can be useful for people with very severe urinary incontinence that need some sort of solution. They are admittedly hard to stick to the outside of the penis sometimes, however. That area can be moist. There can be hair in that area, so it can be a little bit hard. So if you're going to use that, you want to make sure it's fitted properly. The medications that are available, we did a little bit of a preview of this, Mirabegron. This is a mild bladder paralytic. Both men and female use this. And for those people that urge urinary incontinence with the bladder squeezing where it's not supposed to squeeze, this will actually partially paralyze the bladder. I'm kind of obviously oversimplifying it. What we're basically doing is we're reducing those signals that causes the muscle contraction so that it stays and it gives you more time. It's really delaying those signals. It's generally not completely stopping them. It gives you more time to make it to the bathroom. Great medication, tends to work quite well. Side effect profile outstandingly low, but some of those are listed there and you got to watch out for that with your doctor as well. BPH incontinence medications. So you need to understand the mechanism by which this is happening. I alluded to it earlier, but if you have a bladder and it's squeezing, urine through the urethra. If you have a blockage at the level of the urethra, usually from a prostate that's enlarged, it's like a kink in the hose, right? When you kink the hose, what happens? Think of a pump and a hose. If you kink the hose to a pump, that pump starts to overheat, starts to malfunction, starts to have problems, and starts to squeeze when it's not supposed to squeeze. That's the mechanism by which an enlarged prostate causes bladder issues. Blocks the flow of urine, higher pressure in the bladder starts malfunctioning, squeezing when it's not supposed to squeeze, and that's when you have your symptoms, urgency, frequency, and incontinence associated with urgency. So if you can unkink the hose so that there's a normal pressure in the bladder, that bladder can finally heal and hopefully will start to become more functional and will start spasming all the time. That's why these medications work. There's tadalafil, which is low-dose Cialis. You can use that once a day. It increases blood flow to the penis for erections, which is great, a different topic to talk about, but also it relaxes the muscles in the bladder and the prostate so that you don't have to, you don't have that urgency and urge incontinence as much. Flomax, again, is a very powerful medicine, tends to work very nicely. It opens up that prostate, doesn't shrink it, it opens it up so it's not kinking the urethra anymore. That unkinking the hose, again, allows that pump to heal. The pump is the bladder. It can finally heal, starts to become more functional, not being overactive all the time, and that's when you start to see the benefit with the Flomax. It can cause a drop in the blood pressure or dizziness, lightheadedness, can cause a little bit of sexual dysfunction with ejaculate, but overall pretty well tolerated medication. Both of these medications work pretty decently well for enlarged prostates when the enlarged prostate is caught relatively early before it causes too much bladder dysfunction. Issues with these medications, of course, is they often tend to be lifelong medications, but can be quite helpful to improve a man's quality of life. So some long-term solutions for the stress urinary incontinence. I started to talk about this. So far we've been talking about urge with the last one. Now we're going to talk a little bit about stress. Stress incontinence, unfortunately, cannot be managed very successfully through medications. You can do the conservative treatments like the Kegels exercises, pelvic floor exercises, pelvic floor physiotherapy. But if none of that is working really well, the next step is to think about physically helping that valve. Again, that sphincter, that valve, is not tight enough, is not working well enough to stop the leakage of urine. A sling is a great option. What that sling does, again, it's a thin piece of mesh. It's only about 1/2 centimeter in width, and then the length is actually cut to size. What that does is it's like a hammock. It goes on the inside of the body. It pulls the whole urethra up closer to the natural sphincter. So your natural sphincter doesn't change, but it works more efficiently on the urethra and pulls it up in the correct location a little bit more easily to kind of stop you from leakage all the time. The surgery is really quick. It rarely takes you more than an hour or so to do. Folks go home the same day. It's a tiny incision, usually only about maybe 2 to 3 centimeters, more like 3 to 4 centimeters in length. You dissect in, put in the mesh, and close it right up. Less than an hour. It works immediately because it starts to move it to a favorable position and allowing for restoration of bladder control. Great for mild stress urinary incontinence because you have to have some function to your natural sphincter. This is all making it more favorable for your natural sphincter to work. So if your sphincter is completely non-functional, this is not going to work. But if there is some function left over, this will help it work more efficiently. The male sling, it's got good satisfaction. 90% plus of men find that there's good, good results. Again, this is because we choose the right candidate. I and most urologists are very careful about choosing the right person. You want to test them, evaluate them, make sure there is some functional of the sphincter to begin with, and then the sling is going to be helpful. There are always risks like any procedure. Failure, retention of urine, if it works too well or if it kinks off the urethra, which is rare, but if it's done in a certain way, that can happen. There can be some pain or discomfort, although it's usually minimal. Irritation or infections, things like that are always possible. Although I'll tell you, if you go to someone who's very experienced in doing this, overall the risks are quite low. Next is the artificial urinary sphincter. So what if the valve itself, the sphincter itself, is just completely non-functional? It has very little function to itself. There's constant leakage of urine. Well, the sling isn't going to do a whole lot because the sling will move it towards the natural sphincter. But if that natural sphincter isn't even working, it's not going to be able to do anything. So in those cases, this is usually men who are having more than 2 pads per day of leakage. That's when we start to say that the sphincter probably does not have a lot of function left to it. In that case, we put a brand new valve in. It's as straightforward as it sounds. It's actually a cuff. You know what it kind of looks like is if you remember, when kids used to go swimming with those little orange floaties that go around the arm, they button around the arm on both sides. Think of that actually miniaturized into a tiny little cuff. And we wrap that cuff and actually button it around the urethra itself. That's a tube that you pee out of. And that cuff is always on. So it's always closed off. It doesn't fill with air like those floaties do, but with water, saline, that we pre-fill into the system. It's closed all the time. It's wrapped around the urethra so that there's no leakage. There's a little button that's inside the scrotum, inside your sac, and nobody can see it. It's all inside the body. You squeeze it once, twice, and we teach you how to do that, just 2 quick squeezes, and then that cuff opens up for a period of 2 minutes. That 2 minutes is enough time for you to empty that bladder out, and then it'll automatically close back off again so you're not leaking. So it's really mimicking a natural sphincter in its mechanism where it's closed all the time, and it opens up when you tell it to for a short period of time so that you can get the urine out. So this is a nice kind of summary of the way that the artificial urinary sphincter works, because it's a little hard to describe. So this is, of course, zooming in into the male genitalia. You see that tube, that pink tube-like structure, that's the urethra. And that little donut around it is the valve. Now you see when this gentleman pumped it 2 times, that valve opened up, it allows an opportunity to pee, and then it's going to automatically fill back up again. So it's really an ingenious device. The way that it works, it's been around for quite a while now. It's had a few iterations, and the current iteration is awesome. It works quite well for stress urinary incontinence. This is also an outpatient procedure. People go home the same day. It usually takes about an hour and a half, so a little bit longer than the sling to do. Small incision. Again, it's usually about 2 to 4 centimeters in size. It's actually the same incision, more or less, that I do when I put the sling. This is a little bit different in that you don't see results right away. You have to give a little bit of time to heal. There can be a little bit of swelling. You want all the tissues to heal up properly before you start using the device. So usually about 4 to 6 weeks after the surgery, after things are healed, patients are looking good, they come back, we may take a look, make sure the wounds all look good, and that's when we go through the teaching on how to use the device itself. Again, pretty high success rates and satisfaction rates. Again, well over 90% of men who have this find that they're happy with their decision, and it tends to work quite well. There are, of course, side effects with this or risks like any sort of surgery. The main thing is that this is a man-made device, right? No man-made device is perfect. There can be a little bit of residual leakage because you don't make it too tight. If you make it too tight, it could actually wear a hole through the urethra. That's called an erosion. Outstandingly rare if it's done correctly and to the right patients, but you want to avoid that. So you make it just tight enough to prevent leakage. But that also means if you fill your bladder up too much, drink a lot of coffee and tea and water and get really, really full, and you don't go to the bathroom regularly, your bladder's too full, it can overwhelm the valve. So you want to go to the bathroom regularly. There's always a risk of infection, like any implant, artificial knee, artificial hip, artificial valve. Anything has a risk of infection, and it doesn't last forever. On average, this device lasts about 10 years, sometimes longer, sometimes less, before it breaks down by virtue of being a man-made device. If and when it breaks down, you just go in, you replace the device, and you're generally good to go. So, cost and coverage depends for all of these different modalities. But, we always say don't let cost be a barrier. There's usually, there's a lot of insurance coverages when people don't expect. People don't think prosthetics are always covered, but they often are. Even some of the other incontinence treatments, you can often find some insurance coverage. So you really want to work with your doctor to make sure you choose the the best way to help manage this. So, this is again a little bit of summary of the stress urinary incontinence. We talked about the urge urinary incontinence, which is some of the barrier protection, some of the medications. Stress urinary incontinence or behavioral therapies, and some of these products that I talked about or surgeries. They tend to work really well when chosen in the right patient population.
So we're going to start off with some general urinary incontinence questions here. So out of the available medications that you described to treat urinary incontinence, which one would you recommend a patient start with?
Okay. So, again, we're probably going to talk about urge urinary incontinence. Remember, we have the two types, the urge and the stress urinary incontinence. The urge is the one that tends to manage best with medications. First thing you need to figure out is it a bladder problem or is it a prostate problem? That's really the job of your urologist and you as you kind of go through those things. If it's a prostate primary problem, tamsulosin or Flomax tends to be the best. It's a great medication. It relaxes that prostate, allows the urine to flow, decreases pressure on the bladder so the bladder can actually heal in the long term. So it does two things. It reduces pressure so you have less leakage. And number two, it actually promotes healing of the bladder itself by reducing the pressure environment. So that's usually my go-to first medication when you're doing for a prostate problem. If it's a bladder problem, my go-to medication is actually Myrbetriq or Mirabegron. That's a nice medicine because it's got a very low side effect profile and it directly acts on the bladder to relax it. So if the bladder is kind of, malfunctioning, overactive bladder, and you're unable to get it to relax, that's my go-to medication for that. I also have people on both, kind of depending on which is the predominant one, depends on which one I start with.
Ready. Next question here. Is urinary incontinence partially a mental thing?
Sometimes it can be, but I'll tell you rarely. It can be a mental thing because we can have learned behaviors. So for example, there's something commonly referred to, believe it or not, in urologic textbooks of doorknob urgency. So that's when people go to the bathroom as soon as they get home, as soon as they touch the doorknob. That's why that term was coined. They get a feeling like they have to go to the bathroom. That's a learned kind of response when they reach that area, they have to go to the bathroom all of a sudden, and they feel that urgency, they feel like they really, really have to go. That's one of the few circumstances where it can be mental. Otherwise, it's a very biologic phenomenon. It has to do with some sort of dysfunction of the bladder, either due to a high pressure system or other direct damage to the bladder, whether it be from radiation or, long-term damage due to some of the mechanisms we talked about.
Alrighty. Next question. How does urinary incontinence affect erectile dysfunction?
So that's a great question. It doesn't directly affect it, but there's very close relationships between urinary incontinence and erectile dysfunction. One is in prostate surgery. The same mechanism that causes urinary incontinence in prostate surgery can also result in erectile dysfunction. So yes, when you do prostate surgery, you're kind of pulling and tugging at the sphincter, which is what we concentrated on, but you're also pulling and tugging at those nerves. Those nerves have two responsibilities. One is for continence, but the other is for erectile function. So you can see that the relationship is there, that same etiology or same cause that caused the urinary incontinence can also cause erectile dysfunction. Other ways that it can be related is, certain medications that are used can cause, issues with erections. Also, it's also related in the other way. We talked briefly about the Cialis, which is designed to help with erectile dysfunction. It can also help with urinary incontinence by relaxing that bladder. So there are some relationships, but they're not causative. Urinary incontinence should not cause erectile dysfunction. Erectile dysfunction should not cause urinary incontinence. They're separate, but they have some relationships.
Alrighty. Next question here, a bit of a refresher, is can incontinence be cured permanently?
It can be. Depends on what type of incontinence that you have. If you have stress urinary incontinence, the best cure is actually one of the procedures. You can, where you can do the behavioral therapies and stuff at first. Sometimes that's curative for mild. But if it's a long-term kind of problem, which it seems to be what you're alluding to, can you find a solution despite having failed all those? Yes. A sphincter or a sling can be a permanent solution for stress urinary incontinence. For urge urinary incontinence, similarly, if you target the etiology, so what's causing it, whether it be the obstruction or the bladder dysfunction, either with behavioral therapies or medications, that can be a permanent fix, or some of the procedures we talked about as well, like the SNS, sacral nerve stimulators devices.
Alrighty. Next question. I've had urinary incontinence for 3 years. Is this condition reversible?
Depends on the type of incontinence. If it's stress urinary incontinence, like that leaky faucet, the drip, 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 drip after prostate surgery or other valve damage, you're not alone. Actually, most people don't show up until years afterwards. And it is very reversible by some of the things that we talked about, particularly some of the behavioral therapies and the surgeries. Urge urinary incontinence also, just because it's been going on for years does not mean you should give up hope. Those same mechanisms, I follow the same protocol regardless of how long it's been going on, and we found people a lot of long-term solutions.
Alrighty. We addressed some post-void dribble topic discussion during the presentation, but this person specifically says, please address post-void dribble, but more importantly, treatment for a young man.
Okay, post-void dribbling is an interesting phenomenon. So what's happening with post-void dribbling is that urine is collecting inside the urethra. That's the tube that you pee out of, and it's collecting in that column, and then later it just kind of drips out. The reason it collects in that column is, think of the inside of your urethra like a straw. Now, we all remember when we're kids, we're drinking out of straws, and you put your finger at the top of the straw, and then you kind of let go a few minutes later, or a few seconds later, and everything finally dribbles out. That's exactly what's happening with post-void dribbling for most men. Something is blocking the top of the straw, the top of the urethra, for a few moments, and then it finally relaxes, and then everything dribbles out. What's at the top of that urethra or that straw that could be causing a temporary blockage? It's usually your prostate, which can kink on the end of it, or it's your pelvic floor muscles that can kink at the end of it. So, if you describe post-void dribbling to your urologist, that's the first thing they should start thinking about. There's some form of temporary obstruction within the urethra. 9.5 times out of 10, this is the cause of it, and we just need to identify what's causing that little bit of blockage and treat either the prostate or the pelvic floor dysfunction, which is causing tightening.
Alrighty. Next question here. This person is asking, are there practical physical ways to help strengthen urinary flow?
So that's an interesting question. You want to keep in mind that when you're talking about strengthening the flow, you're probably talking about maybe strengthening the bladder muscle so we can squeeze the urine out a little bit better. That's not always a good thing. The reason is if you have blockage of the flow of urine, the way your body reacts is by strengthening the bladder naturally. It's like any muscle. When it's got to squeeze against something that's difficult to squeeze against, it kind of gets stronger, just like when you lift weights, your arms get stronger. When your bladder is squeezing really hard, it's getting thicker and thicker, and it's getting more muscular. In the short term, that seems awesome. You got a little bit of a blockage, just get that pump to be a lot stronger, it'll overcome it. But the problem is think about that analogy I told earlier. When there's a kink in the hose, what happens to that pump? Over time, it starts to malfunction, starts to break down, and in the worst case scenario, it stops functioning altogether. So I find for people who have long-term obstruction, sometimes from the prostate or otherwise, they catch it early, their bladder squeezing really hard and it's fine, they're living fine, and they're able to overcome it. But if they let that condition go on for too long, eventually that bladder is just going to stop working. That's called a neurogenic bladder. Then you become catheter dependent and things like that. It's rare, but not a boat you want to be in. So I generally don't advise bladder strengthening, except in very rare circumstances to kind of help the urine come out a little bit better. Instead, I recommend sphincter, the prostate relaxing or pelvic floor relaxing. So your natural bladder doesn't even have to work quite as hard to get the urine out. That way it stays in a normal, healthy state. It's not hypertrophic, as it's called, so that with its normal function, it can get the urine out the way it's intended to.
Alrighty. Next question here. How can I reduce the number of nighttime trips to the bathroom without surgery?
So there are a couple different ways to do that. Usually when you're having nocturia, which is going to the bathroom at night, there are a few different causes. It can be due to an overactive bladder. So you can target the overactive bladder with some of the medications that we talked about. Another thing you can do is reduce the amount of urine that even collects in the bladder at nighttime. So you kind of adjust when you have your fluids. You tend to have your fluids more during the day before 5 p.m. so that most of the fluid gets processed. And then, at nighttime, your bladder isn't filling quite as much. The other trick that I use for a lot of people is that you kick your feet up during the day. So when you finally lay down at night, and you're laying horizontal, all of that fluid that has been accumulating in your legs, and as we get older, we have less venous return, it's called, so more fluid is accumulating in your legs. It finally comes into the body, gets processed quickly by the kidneys, and then fills up the bladder. So you actually end up processing more fluid at nighttime just by virtue of finally kicking your feet up. So if you kick your feet up during the day and have all that fluid processed during the day, you'll get up less at night because there's less of that fluid processing. So that's one easy trick that I recommend to a lot of my patients. Another thing is watch out for sleep apnea. I've diagnosed sleep apnea so many times for people with their single complaint being getting up at night to pee. What happens is if you get up at night for other reasons, and sleep apnea is a condition where your body doesn't get enough oxygen at night, so it actually wakes you up in the middle of the night with little micro awakenings, so you get a full breath and you go back to bed again. The problem is when you wake up, and you may know this because when you wake up first in the morning, your body does a full body check, and it checks to see, what's going on and what needs to be handled. If there's urine in the bladder, it says go to the bathroom. If you're not waking up at night, your body doesn't do as many of those self-checks, and you don't have to go to the bathroom. But if you're waking up for other reasons, such as, noisy environment, stuff like that, but particularly sleep apnea, you will get that body check and you'll have to go to the bathroom more often. This is well documented in literature. It's a very common phenomenon. And I have cured this just by telling people to do sleep studies. And one of the ways that clues us in on that is if you snore. If you snore a lot at night and you're waking up a lot at night to go to the bathroom, you maybe need a sleep study to make sure you don't have sleep apnea.
Alrighty, moving right along. Next question here. I have difficulty going on airplanes with my incontinence. Any suggestions?
That's a tough problem. It's not just airplanes, it's going out in public. So I have patients that, can't go out in public, they can't go to the mall, they can't go to work, they can't do all this kind of stuff because they're constantly leaking urine. Very difficult problem. It really depends on the type of incontinence, again, that you're having. If it's urge, then you can try some of the medications we talked about. If you're not a medication person, you don't want to take it all the time, well, then just kind of keep some of these medications on hand, maybe a higher dose that you take at the time of your trip. Leaving the house, getting on the airplane, etc. You can, of course, use barrier protection, but those, can be a little bit difficult. You can get some of the specialized underwear that were described that are a little bit more leak-proof, so you don't kind of have that smell or that odor that kind of comes out. Then, of course, there are the long-term solutions that we went over. The main thing I would say is don't give up hope. Find a good urologist, describe your problem accurately, and most of the time we can find a good solution.
Alrighty. Next question here. I saw this more than once. Does gabapentin increase urinary incontinence?
So not always, but I have seen a little bit of that association. So if you have a nerve issue that's resulting in some bladder dysfunction, gabapentin is actually designed to dull the nerve impulses. It's often used for things like chronic pain, like neuropathic pain, which is nerve-related pain, and for other kind of situations when you need to relax the nerves for whatever reason. And it can also, of course, dull some of the signals to the urinary bladder, so that in that way can cause a little bit of a dysfunction. That being said, the association is not incredibly strong, so it's definitely not a definite expectation. But I do consider that when I'm kind of interviewing patients. I go through their medications, look at all their meds, in particular do consider neuromodulators, they're called, whether it be things like gabapentin or multiple sclerosis medications, things like that, certain Parkinson's medications that could be affecting their urinary function as well.
Alrighty. Next question here. This person says, when I work around the yard or do other activities, I have the urge to urinate, but I can't, and then I have leakage. What is this phenomenon and how can it be treated?
Okay. So when you're out and he has urgency to urinate, but then he has leakage afterwards.
Yeah, so urgency to urinate, but when he goes to urinate, he actually can't, and then the leakage occurs after.
Okay. So then I think there are probably two issues going on. One is that feeling of urgency, and then the second is some form of obstruction that's keeping him from urinating. So most likely he's got some sort of obstructive process as his primary issue. It could be an enlarged prostate, or it could be pelvic floor dysfunction where it's too tight. That blockage is causing an increased amount of pressure in the bladder, which makes your bladder a little bit malfunctioning over time because you're carrying a high pressure environment. In that high pressure environment, the bladder likes to spasm. When the bladder spasms, you're feeling that urgency and needing to go to the bathroom, but you can't because you have that blockage. A lot of folks, they need to have the bladder really full so they can kind of really overwhelm that blockage and get the urine out. So there's a possibility that's what's going on. You know, obviously we would have to examine you and do a little bit of testing to be 100% sure, but that's the first thing that's going through my mind as could be occurring in your situation. You may want to, meet with a urologist, describe your history, and they may want to kind of evaluate for obstructive causes such as prostate, pelvic floor dysfunction, or other kinds of etiologies.
Alrighty. So last general urinary incontinence question here. This person says, I use a catheter 5 times per day to drain my bladder. During the day, I will drip a little. Is there a way to eliminate this drip?
You most likely have urge urinary incontinence. So when you're emptying your bladder regularly, you're, reducing, you shouldn't have stress incontinence because it never really gets filled enough to allow for that to occur. But when you're constantly catheterizing yourself, that piece of plastic going in can kind of tickle at the bladder and cause a little bit of irritation. That results in a little bit of a higher bladder tone and an overactive bladder. So when you pass that catheter, it tickles a little bit, you take it out. It might be immediate, it might be a little bit of a delayed response, but it's probably causing a spasm of your bladder because it's irritated and then some of the urine comes out. That's what I'm assuming. Again, we got to take all these with a grain of salt because I'm not there to physically examine and diagnose you, but this is what I see quite common. For that, you can utilize a medication that reduces urinary urgency, dulls your bladder's response to bladder irritants, including the passage of the catheter. Myrbetriq, anticholinergics, in more severe cases, bladder Botox, things like that, could be a great option for what you're describing.
Alrighty. Next group of questions is going to be prostate and prostatectomy related. So the first question here is, does prostate enlargement always lead to urinary incontinence?
No. So prostate enlargement doesn't always lead to it. What it usually leads to first are other forms of urgency: urinary frequency, rushing to the bathroom, getting up at night to pee, feelings like you have to go to the bathroom a lot, and then when you finally go, there's very little to go. These are the initial stages of bladder dysfunction due to an obstructive prostate. If you allow this to keep going on and on, that's when it turns into incontinence, because the bladder becomes so dysfunctional that it just squeezes so hard. That's when you start to have leakage. So, it's usually the end stage of prostatism, it's called, so an enlarged prostate, that results in urinary incontinence.
All right. Next question. When can a man resume sexual activity after prostate cancer surgery?
It's, that first 4 to 6 weeks after surgery, we advise all men to kind of take it easy. You want to do anything that creates a lot of pelvic pressure. So sexual activity is generally not encouraged during that period of time, just because you have fresh incisions, you have new anastomoses or connections inside the body, and you want to allow a healing period. Once that passes, I think it's fine, anytime, provided you're having good erections. And that ends up being the biggest challenge, is the erections after prostate surgery. Again, because those nerves have been pulled, they've been tugged, they start to malfunction a little bit, and so you don't always get a great erection. There is erectile rehabilitation protocols that can be started after prostatectomy that I usually put patients on to promote healing, promote those nerves to kind of heal up faster, so you can get back to sexual activity more quickly.
Alrighty. Next question here is we already discussed a little bit, but do men recover erectile function after prostate cancer treatment?
They can, absolutely. So there's two different types of prostate cancer treatment. Broadly speaking, there's actually multiple ways, but the vast majority of people have surgery or radiation. Radiation actually does not immediately affect erectile function. It actually causes no change in the immediate term. But over time, what radiation does is it prevents regeneration of the cells in and around the prostate, including the nerves around the prostate. So you usually have a slow decline of erectile function over time. For surgery, on the other hand, you have an immediate hit in terms of erectile function, because those nerves have been pulled and tugged as you sweep them away to remove the prostate. In rare circumstances, when you have very severe prostate cancers where the nerves cannot be successfully swept away because we're worried they could be, around the cancer itself, those nerves actually have to be physically removed. The majority of people after prostate cancer surgery, however, you are able to sweep away those nerves, and then they do recover over time. That healing period is usually the first, they say up to 2 years, although realistically it's the first 6 to 12 months that are the most important. During that time, you can promote healing by trying certain medications, which will improve blood flow to the nerves, encourage nourishment of those nerves so they can heal up and regenerate, so you can have erectile function again.
Alrighty. Next question here. Would Kegel exercises be helpful or harmful 5 years after prostate removal surgery?
They are unlikely to be helpful because, the evidence all says that after the first year, especially after the first 2 years, the pelvic floor exercises are of limited benefit. The exception is if you never did them well to begin with, so you never really gave them a good try, well, then I tell people, all right, go for it, give it a try, see if you can, improve the tone of the pelvic floor. But after 2 years, they are of limited benefit according to the evidence. The second half of your question, though, is it harmful? Absolutely not. There's no harm after a prostatectomy when you're trying to strengthen those muscles to give it a try, to work on those Kegels. So I do encourage men who maybe didn't think they did a great job of it the first time, they're like, can I try it? Absolutely. I'll often do it at that point with a physical therapist, because they can really teach a man what's called biofeedback, teaches them how to identify those muscles, how to tighten them properly, how to do proper Kegels, and how to strengthen those muscles as best they can.
Alrighty. Next question here. Why may my body have rejected my AUS, which forced its removal?
So the most common reason for loss of a artificial urinary sphincter is infection. There can be an obvious infection. So, you see that right after surgery. Thankfully, it's extremely rare. But, just like anything, like an artificial hip, artificial knee, it can get infected. If it does, it's pretty obvious. You have redness, you have tenderness, you have, other signs of infection. And in that case, if antibiotics don't work, which they often don't, you have to take the whole device out. Sometimes you can have a little bit of a subclinical infection. Generally, again, that's outstandingly rare, but there is some evidence to suggest you do a long-term antibiotic or something like that to kind of kill that inflammation and see if you can salvage the device. It's actually quite rare to have to remove the device completely unless there's an obvious serious infection. Can the body just reject the device outright? It's conceivable, but quite rare. Everybody is different, of course, but anything is possible.
Alrighty. Next, we got time for about one or two more questions here. So next question is the 24-hour pad weight test the best way to determine if I should get a Sling or AMS 800?
Some ways yes, some ways no. It's a nice objective way to kind of decide on the data to see what's the best way to go. Frankly, I think the best way to decide is by a conversation. So I sit down with my patient, I get a sense of when they're having the leakage, how much leakage they're having, how much it's inhibiting their quality of life, and that by far is the best way to decide. Also to see what they're the best surgical candidate for. Certain things make a sling unlikely to work. Radiation, significant amounts of obesity, certain pathologies or problems with the anatomy can make it so you don't want to do either a sling or a sphincter. So yes, the pad test is an important piece of data, but there are multiple other pieces of data that are just important that you got to consider before you make a decision between the sphincter and the sling, and a lot of that can be figured out just by understanding each other and understanding goals.
If you'd like to learn more about urinary incontinence treatment aids and treatment options, you have a few options. There are more resources in the Resource Center on menmd.com. Visit this page to view instructional videos, guides, expert articles, and more. If you have a question or would like to speak to someone in person, you can also call MenMD at 857-233-5837 or log in to the password-protected secure MenMD portal to schedule an appointment with the MenMD personal health assistant. If you're interested in purchasing an incontinence aid or learning how much they cost, you can do this by visiting the shop page on menmd.com or by calling our office at 857-233-5837. And finally, you can learn more about surgical solutions for male bladder leakage by visiting fixincontinence.com.